This topic is obstructive shock. This is just another type of shock. The body responds to hypoperfusion in exactly the same way. It doesn't care why it's hypoperfused, it just knows it needs to fix it. So remember all those other stages of shock and what the body does in those stages. And now we're just going to talk about what causes this type of shock. This is caused by a physical obstruction to blood flow in, around, and out from the heart, causing a decrease in cardiac output and then a decrease in perfusion. Causes. Let's think of all of those things that can cause a blockage to blood coming to, through, and out of the heart. Cardiac tamponade, so fluid filling that pericardial space on the outside of the heart. Imagine your heart in that plastic bag, and between the heart and the bag, we put a bunch of fluid in there. The heart is compressed, so it's not able to fill completely and then contract and push that blood out completely. Pulmonary embolism. This is a blockage in an artery in the lungs, so the blockage or obstruction is at that lung level. And then tension pneumothorax. That is that air in that pleural space that causes pressure on the heart, lungs, and great vessels. So what will this client look like? They'll have hypotension. There's less blood getting through the system. In response to that, the sympathetic nervous system will then cause tachycardia. Remember, low blood pressure, tachycardia. The client will have rapid, shallow breathing and tachypnea. The client will have impaired perfusion. Remember, not enough blood is getting and pumped out of that heart. So what does that look like in the periphery? The client will have weak pulses and cool, clammy skin and delayed capillary refill. They may be cyanotic, and then with impaired cerebral perfusion, they'll have altered mental status. Some of the clinical manifestations are going to be specific to the underlying cause. Like pulmonary embolism, that client is going to have chest pain, shortness of breath, and dyspnea. Cardiac tamponade, they're going to have Beck's triad. They're going to have hypotension, jugular vein distension, and then distant, muffled heart sounds. Now let's remember those stages of shock: initial, compensatory, progressive, and irreversible. If we don't intervene quickly enough, the client progresses through those and complications happen. Complications like multi-organ failure from lack of perfusion, arrhythmias, cardiac arrest, and death. We need to stop the progression of shock. If we suspect our client is showing signs of shock, we need to act. First, the client will go through diagnostics, like a chest x-ray or echocardiogram. That's going to show us where that obstruction is. Then we can treat the cause of the obstruction. For cardiac tamponade, that's pericardiocentesis. It is echocardiography-guided needle placed in that pericardial space to remove that blood. For tension pneumothorax, needle decompression and then a chest tube. And for pulmonary embolism, an embolectomy and anticoagulation therapy. These clients will be on cardiac monitoring and will also monitor their vital signs and level of consciousness. We can provide supplemental oxygen and prepare them for potential intubation if they decline. We can provide fluid resuscitation. The type of fluid and amount depends on the client and situation, but normally crystalloids and colloids are used. And then we'll record intake and output. Remember, the body responds to hypoperfusion the same way. It doesn't care why it's hypoperfused. Obstructive shock means something's in the way. Keep up the good work. I'm proud of you.